else that needs to be added to this network, please drop me a line. We're adding people every week, but we've also had to remove people at their request because some people have moved on to other roles as well. So please bear with us as we align everything. And we know that we'll still have colleagues coming in, but I will hand over to Carol, who will introduce himself and take us for the first 8 to 10 minutes segment. Over to you, Carol.
Thank you, Jeanette. Really lovely to be here, and hi, everyone. As Jeanette said, I will do a sort of a very brief introduction to, I guess, mindfulness with elements of body scan and something called the special place. So for that, what I would suggest is that first and foremost, if you could pop yourself on mute, that would be super helpful. Also, if you could switch any notifications off as well, because sometimes, you know, if we go into these spaces, it would be nice not to have any distractions. My name is Karol Kuchera. I have a sort of dual role. I work in equality, diversity, and inclusion, as well as the staff experience and well-being. So I guess we've got quite a packed agenda for today. So I suggest we start. So first of all, I'd like you to start with just becoming a little bit aware of your surroundings and wherever you are right now, and just pay some attention to where you are. Start by getting comfortable. Switch off those notifications so you won't get disturbed. And just gently shift your attention to your breathing. And just notice there's nothing you need to do there. Just notice how your breath rises and falls. Perhaps you may start feeling that the breath starts quite naturally traveling towards your belly, and it's almost like a balloon that inflates and deflates itself. And now just very, very gently nudge your attention towards your feet and place them firmly on the ground. And in a minute, I'd like to invite you to do almost like a spotlight search of your body. So it's almost as if you had a light that was traveling through your body, and just noticing any sensations that may be arising, starting with your feet and slowly moving up, perhaps through your calf muscles to your knees, and then to your upper legs, to your buttocks, to your back, to your upper arms, lower arms and hands. Now just gently towards your chest, towards your face and towards your head. And just notice, just observe. There's nothing you need to do there, just to observe. And again, slightly shift your attention towards your breath. And if you haven't done so already, I'd like to invite you to gently close your eyes. And perhaps if that's not possible for you, just find a point and just use that. Just blur your eyes a little bit. Just blur your focus. And in a minute, I'd like to invite you to think about some space that you have been or imagine being. It feels very safe and calm for you. It's a peaceful, it's a safe space. Maybe a place you've been to before, somewhere you've dreamed about going to, or somewhere you've seen a picture of, or just a peaceful place you can create in your mind's eye. Look around you in that place, notice the colors, notice the shapes. What else do you notice? Now notice the sounds that are around you in that place, or perhaps the silence. Notice the sounds that may be far away and those that are near to you. Notice those sounds and the difference between those that are more noticeable and those that are more subtle. Now think about any smells perhaps that you notice there. Now focus on any skin sensations, maybe the earth beneath you, or whatever is supporting you in that place. Temperature and the movement of air, anything else you can touch. Notice the pleasant physical sensations in your body whilst you enjoy this safe space. And take a deeper breath. Now, whilst you're in your peaceful and safe space, you may choose to give it a name, whether one word or a phrase that you can use to bring that image back anytime you need to. You can choose to linger there for a while, or just enjoying the peacefulness and serenity. And in a moment, again, I will ask you to shift your attention slightly bit back to your body, back to the points of contact your body makes with the chair or wherever you sit. Notice again how your feet are reconnecting with the ground beneath you. And just gently wriggle your toes. Whenever you're ready, just take a deep breath and allow your eyes to open naturally. So welcome back. Jeanette, I'll hand over to you.
Thank you, Carol. Again, I'm always afraid to speak in these moments, and hopefully we're all feeling a little bit more grounded, feeling that we've had a little space for ourselves in this moment before we go into the rest of the agenda. Please message us if there's anything, or if at this point we have a bit you want to unmute or say anything, please feel free to do it now. I'll pause for a few seconds. I'd just like to welcome Helen into the space.
Good morning all. Hi, I'm Helen Teseo and I work in the National Retention Team. This is the first time I've joined such a meeting and appreciate there's quite a number of people on the call. Can I just see a show of hands for people from NHSE and I People Directorate, if that's okay, please? Just so I've got an idea who's on the call. Okay, fair few number. And can I see a show of hands for people from systems in the Southeast or organisations in the system? Got one? Okay, a few more.
Yes, most of our health and well-being leads are from organisations across the Southeast, Helen. Yeah.
Okay, that's really helpful. I am actually on annual leave today, but I wanted to join this because I think it's important, and it would be lovely to talk to you about retention, and especially since we've got systems on the call as well. So I, as I said, work in the national retention team, but aligned to the Southeast and its constituent systems. So everything we do is based upon the People Plan, which was published July 2020 in the midst of COVID, of course. And as such, what we're trying to do is accelerate the health and well-being element of that, and a lot of learning from COVID. And that goes for all staff. Everybody is really valuable, very important, has something to offer and has something to gain. It isn't a dichotomy of clinical and non-clinical, medical and clinical. It's absolutely everybody, 1.3 million of us in the NHS and health and care broadly. So that's the context. And in terms of retention, you know, we focus on the People Promise themes, and I'll just very quickly run through what they are. So it's learning and development, equality, diversity and inclusion, and creating that supportive culture in which we can all flourish, and supporting the team comradeship, an element of team, and safety and well-being. And that's the bit I want to focus specifically on. So we've got a number of retention programmes which focus on health and well-being. So whilst I've said it is for everybody, and it is for everybody, there are some slight nuances and differences between health and well-being of medics and clinical staff and non-clinical staff. Medics, for example, is an area where people are least likely to engage with health and well-being support for themselves. So we need to do something about looking after the people who look after the people. So I'm just going to very quickly run through a bit of an update nationally on health and well-being. I've noticed a few hands are up. Leslie Ann, did you have a question, or is that a legacy hand?
Legacy, okay. Sorry. Yeah.
That's fine, no problem. I just wanted to run through very quickly just some of the updates on a national level from health and well-being, and then I can talk about how that links to retention later on. But Jeanette, if I'm running out of time, just poke me. Okay. So the launch of Wellbeing Guardian guidance is due at the end of this month, and the key priorities within that are line managers, team and wellbeing conversations, senior leaders, wellbeing campaign, health and wellbeing guardianship, mental health support, and occupational health service transformation. There is quite a large-scale reconfiguration of that service presently. And then one of the speakers was Radhika Nair. So that's about the just and learning culture, creating an environment where people feel able to speak. There was a clinical fellow speaking to the group about a national weight management offer. We have 360,000 of our workforce potentially classified as obese, and a high prevalence amongst nursing staff, which can impact on well-being and productivity. So there is a procurement process for that, for a digital platform level of support for that, including support with food and nutrition and physical activity. We also have a retention hub that we're looking to promote that and other offers on. And then more broadly about health and wellbeing, we have wellbeing apps and digital platforms that NHS staff are all able to use, and that has been extended until March 2021. There is scope for it to extend beyond that, but as of yet, we're not in a position to be able to confirm that, but certainly until March this year. The important thing to say about health and wellbeing support offers is that it's available to nursing students as well, and those in primary care. I think it's really, really vital that we don't inadvertently exclude any very key workforce cohorts who also may want to access health and wellbeing support. We also have financial wellbeing, because this is talking about pensions and plans for pensions and retirement, working with the Money Advice Service. So that's all upcoming. And I mentioned previously the Enhanced Occupational Health and Wellbeing community event programme. So that's linking in with the mental health hubs. I'm not sure how familiar people on this call are with what's going on, so apologies if this is all stuff you already know. But there are 14 occupational hubs that have been established nationally. I'm not sure how many in the southeast, but I can find out. And they work with NHS employers to capture experiences of the programme. So that's the broad overview of what's happening nationally. We've got a health and wellbeing lead in the oh, Fiona, thank you, there's 2 in the southeast, thank you. We've got a health and wellbeing national lead who I can receive more updates from. But in terms of retention in the southeast, I do want to give a bit of time, if I may, Jeanette, just to talk about that. So we've had 2 kind of separate but linked pieces of funding to stretch out a couple of programmes. So one is about flight risks. And what we see in the NHS in the main is that there are 2 ages at which point people leave. And when I say leave, I mean leave the NHS entirely, not leave to go to another trust or primary care. And they are, broadly speaking, in the southeast, age 34 and 54. So those are our flight risk areas or cohorts of age, and that has given rise to programmes of support around flexible working, flexible retirement options, and supporting people to feel listened to, supported, an element of belonging and support in the workforce. I'm not sure if people have seen the leaver rates that go up to kind of November 2020. So the leaver rate has dropped in England and in the southeast, which is pleasing to see, but we can't be complacent because that is likely to be people who are hanging on until COVID has all but passed its peak impact. And are delaying, post-work plans such as retirement and flexible working, reduced hours, that kind of thing. So we need to be, really looking after that cohort of people, and that flight risk piece of work is really important. I don't know if anyone from Hampshire Hospital, Solent or Frimley are on this call, but we have representatives from those trusts. So we've got community and mental health and acute trusts embarked on that programme, which is fantastic. If there is anybody else interested, please let me and Jeanette know. There is still scope for further expansion, and it would be fantastic to see more people represented from the southeast. And so the other piece of work was a relatively small pot of funding to support health and wellbeing in one of the local systems or one of the local trusts in the system. And we identified Kenton Medway ICS and specifically Medway FT within that. And that is about supporting practical and physical health of people within the trust. So we've got a business case supported with them on a gym for that cohort of staff, and will be expanded to others within the system through the passage of time. I've just seen a few comments pop up, so I just want to respond to those before I finish, Jeanette, if I may.
Yes, of course, Helen, go for it.
Okay. I'm just reading someone's probably a hangover from last week. So there's lots of offers. What I've learned in the primary care space, and it's applicable here as well, is that there's national offers, there's regional offers, there's local offers, and there's what people just do by osmosis and work out their own health and wellbeing support offers themselves. So sometimes it's about linking them up, and a few people have mentioned other localised support offers for health and wellbeing. So I'd love to talk more about that. Leslie Ann, for example, you've mentioned about the Reset Health programme, including weight loss, which sounds like we definitely need to link up about that, which would be fantastic. And then Louise Hall, you said about Royal Surrey. I presume that's to do with one of the flight risk programmes. So I'll just drop my email in the contacts in the chat box so that anybody can get in touch. But that would be great to hear more about that. And actually, Royal Surrey was one of those that we did have an early identifier for, because it felt like I think it was predicated on the leaver rate at the time, but things change rapidly. And then we also look at the number of absences due to COVID and reacting. So there's something about the immediacy, and there's something about the medium and long-term plans for health and wellbeing. So that's it. I won't take up more of the agenda, but thanks, Jeanette, and I'm very happy to talk after this call if anybody would find that useful. Thank you.
Thank you, Helen. You've covered so much in such a short space of time. And what Helen, and thank you for coming on your annual leave as well and giving us part of your time.
That's right, there's nothing else to do anyway.
There is so much happening in that space. Carol, can you see if there's any hands raised, or because I can't see at the moment before Helen leaves us. And Helen, there's only one more thing. We did send out the email about the workshops, the early years, and we have said, can people still book in for those? Yes, they can. Ideally, by the end of this week, please, just because we do need to manage the attendances and manage the agenda and numbers, etc. And this is a national offer, so we will get quite a number from the other regions, no doubt. But please do put yourself forward. I don't want anyone to miss out just because of they missed the timescale or anything like that. Thank you. And that's a specific workshop, which is an engagement process to talk to colleagues in the NHS who may have started with us their career at the beginning of their career, and then other colleagues who may be more at the end of their career. And the retention team are capturing feedback. And it's next week, it's short notice, and we have sent the email out again. But if there's any specific queries, please let myself or Helen know. And when we send the update, we will send Helen's details as well. Thank you, Helen, so much. Okay, I know Mark and others are keeping an eye on the chat box fee, because my chat box has gone at the moment. And I would just like to hand over this next segment to Carol. And Carol, I'll let you just frame what you're going to be talking about. Thank you.
Thank you very much, Jeanette and Helen. And actually, it segues quite nicely, because we are going to be talking today, not an easy subject. It's neurobiology of trauma and post-traumatic stress. However, you know, this is very relevant to what Helen was talking about, especially, you know, in terms of the retention of staff as well. So I've got a nifty presentation for you today. So let me just go into present mode. I should take about 20 minutes of your time. Few things to kind of before we start. Obviously, this is not intended, but some of the information discussed here today some people may find that upsetting. Please look after yourself. You're not obliged to listen to the presentation, so take a break, breathe, ground yourself. You may, I've given different examples here of how you may do that. So look around the room, feel or stamp your feet on the floor. Think of your favorite holiday. Jeanette. Okay, think of your favorite holiday or special place that we've just practiced. Splash some cold water on your face, etc., etc. I think it's fair to say that most of us have experienced some stressful or very stressful events in our lives. But please do not share your personal stories or experiences of trauma, especially in this sort of space, as this may trigger others. And also, I will make myself available after the presentation if there's something that has come up for you and you would like to discuss further. So what we're going to cover today, just very briefly, and this is going to be a very sort of whistle-stop tour of post-traumatic stress. So we're going to talk about neurobiology of stress, diagnosis of post-traumatic stress, as well as some treatment options and emotional regulation. In the next slide, there is a brain on it. So if you're feeling squeamish, please look away now. So before we start, I just wanted to tell you or share with you really my passion for post-traumatic stress, because it is something that affects our brain. Now, it is estimated that we have about 86 billion neurons, and neurons are obviously the nerve cells in our brain. So 86 billion neurons in our brain. Each and every one of them is capable of making up to 10,000 connections with other neurons around them. And there is a professor of neuroscience in Oxford. His name is Vilna Ramachandran, and he very famously said that there are more connections in the brain, in your brain, than there are known atoms in the universe. So just contemplate that. And by the way, this is an MRI scan of my own brain. So you are literally right now looking into my brain. And isn't it quite reassuring that there's something in there? So I wanted to start with some data that came out from the BBC survey that has been done in the first post our first lockdown. So we are already seeing that there is an increased adverse impact on mental health of our frontline staff, and we know it anecdotally, but also this survey kind of confirms this. So in the 1,194 UK frontline health and social care workers, 47% met criteria for anxiety as well as depression, and 22% met criteria for post-traumatic stress. Now, the usual prevalence of post-traumatic stress in general population is 8.6% in women, 4.1% in men. So women are more prone to develop post-traumatic stress, twice as much as men. Now, the current data from that survey, if you do some calculations, suggests that there's a 2.5 increase in PTSD symptoms in women and 5.3 in men at the moment. Well, or at the time of when that survey was done. So this is probably a bit of a flashback to your biology lessons. I hope that's not too traumatizing. But in terms of the stress and stress response, three main brain areas are involved with that. So that's hypothalamus, pituitary gland, and adrenal gland, and that is called the HPA axis. So the hypothalamus links the nervous system to the endocrine system via the pituitary gland. The hypothalamus is responsible for hunger, sleep, temperature, heart rate, as well as memory. And it stimulates the pituitary gland to release corticotropin, which stimulates then the adrenal cortex atop of our kidneys. And pituitary gland is responsible for stress, for growth, for reproduction, and for lactation. As this is happening, the adrenal gland releases the cortisol, which is our stress hormone, which initiates that stress response. And this is a very, very rapid activation of that fight, flight, or fight, flee response. But via the negative feedback loop, it suppresses the hypothalamic and pituitary hormones, so everything kind of downregulates by itself. However, the studies of post-traumatic stress have showed that there is either hypo or hyper-regulation of that HPA axis, so it doesn't work very, very well. What is also important to state here that we are wired biologically to respond to potentially threatening environmental cues, which activate that threat system. And it's a very rapid system. So if you imagine an example of walking down the street, you want to cross the street, all of a sudden you notice that a car is coming towards you. That system has to be very rapid, otherwise we know what's going to happen. I really like this quote. It's better to mistake a stick for a snake than a snake for a stick. And the efficacy of this system very much depends on that rapid activation, effective termination, and then adaptation following the onset of the stressor or the threat. So just to give you an example, so, you know, with the snake, what's that? It's a snake. There's that recognition activation. Oh no, it's a stick. Termination. I can calm down now. We adapt to it. And this made me laugh. Right. So we've got, in terms of the classification of diseases, we use two Bibles, or two books, shall we say. One is the ICD-11, the current version, which is published by WHO, and there's the DSM-5, which you probably have heard of, which is the American version. So the disorders that are specifically associated with stress, and they directly relate to exposure to stressful or traumatic event, or series of such events or adverse experiences, are post-traumatic stress, complex post-traumatic stress, prolonged grief disorder, adjustment disorder, reactive attachment, disinhibited social engagement disorder, and other disorders as well. But it's important to remember that post-traumatic stress, the stress is the key word here. So what's the difference between trauma and PTSD? Because very often you hear these kind of two words being used interchangeably. I particularly like the definition that comes from Lindemann in 1944 about psychological trauma, that the psychological trauma is a sudden, uncontrollable disruption of affiliative bonds. So I like to think about it that we all have a certain worldview. We all know how we operate in our worlds, in our ecosystem, shall we say. And psychological trauma happens when all those bonds that we created and those affiliations that we created, when they are severed very, very suddenly and uncontrollably. Now, post-traumatic stress is a difficulty or inability to recover from stress reactions to a traumatic event. So to kind of put it quite simply in terms of the hallmarks of trauma, and you will have to have all three of them in order for that to be to develop into post-traumatic stress. So first of all, hypervigilance. So what is hypervigilance? It's a vigilance towards potential threat and increased level of arousal as well. So as an example, you may experience some sleep difficulties, irritability, and concentration problems. Then we've got avoidance and numbing. So we avoid the situations of the stimuli that could reawaken the trauma. And for example, you may be avoiding certain news. You may not want to switch the TV on. You may even start numbing your feelings with substances such as drugs and alcohol or whatever, or food. You also may start withdrawing from others. And the third part of it is about intrusions. So this is about re-experiencing the traumatic event. Usually it comes in forms of flashbacks or nightmares. So some examples. So examples of traumatic events which you may experience or witness on a singular, repeated, or multiple times, which are associated with development of PTSD, are serious accidents, physical, sexual assault, abuse, including childhood or domestic abuse, work-related exposure to trauma, and you know that links directly to that BBC survey and post-traumatic stress of the frontline workers. And that includes also remote exposure, and I will come back to it in a second. Trauma may be also to do with serious health problems or certain childbirth experiences. It may develop during war and conflict, and I think the most often whenever we think about post-traumatic stress, we're thinking about the soldiers coming back from active duty, but also torture. So to develop PTSD, we have to be exposed to a traumatizing event or events. In normal circumstances, we cannot traumatize ourselves by the very act of our imagination without any prior exposure to trauma. So, for instance, going back to the including remote exposure. So we would have to have some form of underlying stressful or unresolved events that may link up to, for instance, hearing about something. So we may not necessarily be exposed to that directly, but we may be exposed to it indirectly, and it's called vicarious trauma. So sometimes, for instance, some therapists may develop vicarious trauma on the basis of just listening to a high volume, for instance, of traumatized clients, and that's why supervision and self-care is super important. So as an example, I just threw it there. Some people who may suffer from obsessive compulsive disorder may experience a lot of ego-dystonic thoughts or images, but they are fleeting, they are non-enduring, and they cannot produce symptoms associated with PTSD. I know that was a lot, so take a breath right now. Again, feel your feet on the ground, or whatever you're doing, maybe look around the room. And we will move on. Okay, so how is PTSD diagnosed? And the majority of the diagnosis in this country is going to be actually happening within the improving access to psychological therapies or IAP services. They will use something called PCL, or in the past they used to use IESR, which is a very rapid kind of checklist looking at these different elements so re-experiencing avoidance and persistence perceptions of heightened current threat. So is that hypervigilance that I was talking about. There are certain thresholds, so it's not like you just tick one on every one of them, on every one of the questions, and that means that you have diagnosis. It's a sort of a suggestive diagnosis. It's working with a formulation rather than necessarily diagnosing people. So this is about looking at whether these particular events that you've been through have had an impact on you. And the cutoff score for this PCL5 is 31 to 33. I wouldn't suggest self-diagnosing. So what do we do in terms of recommended treatment? So National Institute for Clinical Excellence suggests about typically 8 to 12 sessions of either trauma-focused CBT, the PTSD which presented for more than 1 month after the traumatic event. So the 1 month is the cutoff place, because we may be exposed to traumatic events and not develop PTSD. And that period under 1 month is called watchful waiting. And those symptoms may resolve by themselves. Secondly, we offer something called EMDR, which stands for eye movement desensitization and reprocessing, which is like a specialist type of working with the trauma, but that is offered after 1 month to up to 3 months. And then again, EMDR is from 3 months onwards. For some people, this may not work, and trauma-focused computerized CBT may be appropriate. However, the efficacy of it is better to see somebody, and it's better to kind of to work through it, either through trauma-focused CBT or EMDR. Important caveat here, I think, is to say that counseling is not recommended by NICE as a as a treatment for post-traumatic stress, unless the counselor has been trained in any of the above, so in cognitive trauma-focused CBT or EMDR. Now, there are some other modalities that work with trauma and work with trauma effectively, but they are not recommended by NICE. In terms of the pharmacology, generally it's better not to offer drug treatment unless it's necessary. Definitely not using benzodiazepines because they interrupt memory formation, and some venlafaxine or SSRIs may be used for that, or in some severe cases, antipsychotic drugs may be used as well. So just to finish off, in terms of the emotional regulation, and you may want to use it or look at this for yourself. I've written out some really nice kind of and simple techniques that will help you ground. My personal favorite is the 5-4-3-2-1 technique, which is you think about if you have any kind of flashback or if you have any kind of emotional disturbance, you may think about 5 things you can see, 4 things you can hear, 3 things you can touch and touch them, 2 things you can smell or like the smell of, and 1 slow deep breath. You can add 1 more to the end of it, which is 1 nice thing about yourself. So that's it from me. Thank you very much for listening. I hope this was helpful, and yeah, I'll happily take some questions if there are any.
Thank you. Thank you so much, Carol, for taking us through that and raising awareness, and also giving us the difference between trauma and PTSD. It's so relevant now, especially in the midst of COVID. So I know that there are some questions, and Fee, I can see your hand. Yes, go for it.
Thank you, Carol, for a really illuminating time to really focus on something that's affecting a lot of people. One of the conversations we were actually having yesterday was around there isn't a set circumstance that is traumatizing. It is, you know, often one of the issues that we see across staff is they may not recognize that they are traumatized. And I just wondered what you might offer for the community here today around how we can support staff when they don't recognize that they have been traumatized, whether they've been in kind of, in inverted commas, traumatizing experiences or not.
Yeah, it's a really good question and not an easy to answer. I think paying attention is the first and foremost thing, or the best thing that we can do for somebody. Offering a psychologically safe space where people can come to us and can talk about what is happening to you. It may be that at the very first time when they come in contact with you, they may not be able to articulate exactly what is happening for them, but perhaps we'll be able, you know, with time and also with your increased knowledge, you may be able to spot certain signs. Another thing is that if you perhaps offered certain interventions and you're seeing that they are not necessarily working, then that may be a trigger point for you to kind of to consider, well, actually, maybe there's something else going on. And as I say, with the trauma itself, or with post-traumatic stress itself, you have to have the hypervigilance, intrusions, and avoidance. Now, somebody may come in and they say, "Oh, I've stopped, going there or seeing these people or watching news, etc." And that may be a very natural response to, everything that is going on right now. We are quite overwhelmed by all sorts of difficult news around us. So we may use that as a coping mechanism. But if on top of that, you also noticing that this person is very kind of jumpy, easily startled, they reporting lack of sleep, and they report lots of images coming to their mind, then perhaps you may start thinking or formulating that, I wonder what this might be about. So that's one thing. Secondly, we will we will have hopefully Dr. Giles Allen coming to this space, talking to us about trauma-informed practice as well. So that's hopefully will happen in a couple of weeks' time. So you will have a better understanding of that as well. So today was just furnishing you with the kind of information what post-traumatic stress is, and and how to understand it.
Thank you, which is something we all need. Yeah, and I think it brings us nicely on. Fee, I know you wanted to say a few words about resources that are coming out. I can't see if there's any more hands at the moment, but please, obviously, if there's anything else, please put it in the chat box. If there's something we haven't addressed today, we will get back to you. We will send the slides out as well. And we know that you, as health and wellbeing leads, that you're in the middle, you're taking information, you're translating it, you're organizing support. But one of the things we would want you to think about is your own self-care as well. Leslie Ann, I'll give way to you. Yeah.
Thank you, and thanks, Carol. That was generally one of the most interesting presentations I've seen, particularly this time, and really helps where we are at the moment. One of the big things that's cropping up time and time again now in our trust, and we are a trust that has previously lost a clinical member of staff to a suicide, so it's something we're acutely aware of, is how do we engage the clinicians more in this? They do seem to be the group that are least likely to come forward with their own needs and concerns. They're very good at looking after everybody else, and even when you talk to them, what I get fed back from our internal teams, it's very much kind of yes, I hear you, or yes, I'll, and then they wander off and it's forgotten. Are there any tips or hints to actually breaking through that somehow?
Yeah. Wow, yes, again, great question. Not sure whether there's a simple answer to it. I think in particular, people are very much queued up as to when they start noticing you changing. So your immediate environment will start becoming aware that something isn't quite right, that perhaps, there's increased emotional lability, that, perhaps people become very, very, snappy, or they just want to get on with it. And, so you will start noticing that there may be some subtle kind of changes in them, or they may start reporting to you, well, actually, I'm not sleeping very well. And I think that the more we will all furnish ourselves with the information and the knowledge about this, the earlier we will be able to spot the early warning signs. And I think this is very much where this work needs to go, about spotting the early warning signs and kind of trying to act in a way that is going to be helpful and supportive. Because it's a little bit like, have you seen this video? It's not about the nail. Okay, I'll drop that. but it's like, it may be obvious to everyone else, but it may not be obvious to the person. So that should be a cue as well. So, kind of gentle approach and just seeing, creating that psychologically safe space and saying, well, actually, shall we have a chat? Shall we have a cup of tea and see how you're getting on with stuff?
Yeah. I'll just bring, Eva has her hand up as well, so I'll bring her in after you, Carol.
Great, sure.
Carol, thank you. I did do biology nursing a long time ago, but that was really up to date and informative, accurate, really, really well done. And I think so. In 2019, for those of you who are not HR directors, Carol was leading, when Carol and I worked for Health Education England, Carol led a program of work called Trauma-Informed Practice for HR Professionals. And at the time in 2019, we were talking to HR professionals about trauma-informed things within race. We were talking about how when you put people of color through disciplinary process, we pulled out things around how it traumatizes them in terms of process, and we related that to disability as well. Now, in this space for health and well-being, maybe, Carol, we need to think about some of the work we did with Dr. Giles Allen then, and what you can do in this space. Although we might not focus on race or disability as protected characteristics, we might focus on people in general, but it's something certainly that Giles and I are still working with in HE with the doctors. So maybe you and Fiona can have a chat about that offline, but see how we can pull it into this space.
It's happening in 2 weeks' time.
Oh, is it?
Yes.
Well, Fiona is ahead of the game.
Great minds think alike. So, and that's in response to the feedback, Kavita, that we've been getting. Christina Simcox, who's on the call, is speaking to the leads. So we are trying to ensure that we listen, we hear, and we respond. Yeah. Okay, so if there's anything else, Fee, did you want to say anything about resourcing? Then I'll go to Christina briefly for us to wrap up, but do stay with us. We have a few more bits. Go ahead.
So I'll just, in a very short nutshell, recognizing that thank you for everybody that has shared what you're focusing on at the moment, where you see the gaps, what your needs are, a bit like Kavita was just raising there. You know, we know that a lot of these needs are still coming in, and do keep letting us know. Based on what you've asked from us, we will soon, I'm hoping this week, it might lead into next week, come out with a very simple signposting guide that is particularly focused for staff who do not have access to emails and intranets, or at least are perhaps so overwhelmed that they're not looking at those things. So the team are putting together something really simple that you can print off to put on notice boards for porters and healthcare assistants and vaccinators and all sorts of groups that are not necessarily getting through your normal channels. And that's just something that will be editable, so you can put in your local offers, but it includes some of the national and regional stuff. And then that will be channeling through to a refreshed part of the website, which will be launched very soon, which is very focused on not sharing all of the resources we have, but on really trying to make it manageable based on what your need is. So whether that is in terms of where somebody's at in the mode they're working at, whether they're in survival mode, or whether they're looking for transformation and growth and everything in between, but also for target audiences. So whether that is staff that are working in high-risk areas. We've also had a lot of requests for some specific stuff for those working remotely, and a lot of those working remotely for the first time, and teams that are split between those kind of operating environments. We're developing resources for parents. So a lot of it is what already exists and just making it an easy to access first point of call, but also, for example, working with some kind of known professionals around the area to give some clear messaging that's very simple and easy to digest. We've heard about the mental health hubs a lot through these calls, and while they will each in their own region have their own front door and you access them directly and line managers can do direct referrals, we will be a sort of here are some contact details and easy to find things, so that you don't need to worry about kind of hanging on to all of that stuff. There will also be a sort of private page, if you like, for HR directors, people directors and workforce leads, for us to keep in one place some good practice, guidance for developing particular programs and things like that, so that you can draw off on what already exists across the system, both developed through NHS I&E and also through your partners and neighbours around the southeast, so that it's a sort of easy to access thing that's you know, somewhere you can search for things that have already been developed. So do please keep sending Christina and the team your good practice, because that is where we will be sharing some of that stuff. So just 3 things I want to leave you with for you to be aware of. And as Kavita highlighted, we've got a program sort of developing over the next 6 weeks or so for these networks. to try and make sure that you're really getting what you need from these. So share what you need, and we will be kind of learning more. I mean, next week we'll be quite focused on that almost as a topic in itself. So hopefully you'll get some real value from understanding where everybody else is at in the system with that. Think about your own well-being, and our bite-sized coaching offer is available already on the website, on the Leadership Academy website. You can book coaching. It's fast access. It's a sort of one-off session to really help with what you're facing right now, and not underplaying what you're facing is important, because the trauma and the stress and anxiety that you'll all be faced with day to day have an impact. The other thing I want you to be aware of is the Faculty of Medical Leadership and Management offer that we're partnering with them on for medical directors, nursing directors, clinical directors, those operating in a sort of clinical leadership environment where we know there is so much pressure at the moment. That's on the website already. So you can kind of promote that if people haven't heard about that already. And the other one I've already mentioned. So there we go. That's all. That's everything from me. We will be sending a communication out later this week with those materials on in a really simple way, so that you can get them out through your channels within the trust. We won't be going to them directly, because we want you to be the conduit, so you know what messaging is going out.
Thank you so much, Fee. That's so helpful. And this time I just want to bring Christina in. A number of you have had conversations with Christina. If you'd like to put your camera on, and we would want to continue to communicate with you to find out, not only in this session, but offline as well, what would be useful for you. So I know Christina has emailed a number of you, and even if that's a very short space of time with a telephone call that Christina can have some time with you, we would welcome that, because that will help us to continue to build in. So we're in the short term, medium, and then there is the long term as well, in terms of what you need as health and well-beings and what we need to be doing together across the region. So that's it in terms of the updates. Before we go, if anyone wants to pop their hand up if there's any questions, or you want to unmute or put anything in the chat box, we have a few minutes left. Is there anything anyone would like to say before we? Okay, so that just leaves me to say thank you very much for everyone coming on today. Thanks to all our speakers, Helen, Carol, and everyone else that's contributed. Huge thanks to Mark in the background with our technical support. And I'll be on for a few more minutes after. I know some people need to be released and to go back. Feel free, and I'll be in the space for a few more minutes, and we'll have some further updates for you next week. So bye everyone, and have a fantastic week. Oh,